The following podcast is part of a certified educational activity titled Quiet Progression, Loud Impact in MS. Expert insights on the role of BTK inhibitors beyond relapse. Access the entire activity and complete the post-test at peerview.com/CXV860. Downloadable slides are also available.
Hello, everyone. My name is Jiwon Oh, and I'm a neurologist and MS specialist at the Barlow MS Center at St. Michael's Hospital at the University of Toronto. I'm the medical director of our MS Center, and I'd like to thank you for joining us to review the latest evidence on BTK inhibitors in MS, which was presented at ECTRIMS 2025. So, the objectives of this session today are to review the latest evidence of BTK inhibitors in MS. We'll also end with a discussion of the potential role of BTK inhibitors within the MS treatment landscape, and then to talk about potentially which patients with MS may benefit from treatment with a BTK inhibitor if approved. Okay, so just to start with a bit of background, I think everybody is probably familiar with the fact that the MS field has recognized in the past decade or so that there are two simultaneous pathophysiologies at play in MS, and this is across the entire MS disease spectrum, even in people initially diagnosed with relapsing MS, and even at the later stages of disease in people who have had a long disease duration and have many features of progressive MS. And so what we're recognizing is that relapsing disease pathophysiology, which is often thought to be mediated by peripherally mediated inflammation, plays a major role throughout the MS disease course, but often plays a greater role in relapsing stages of disease and in earlier stages of disease. And then there's progressive disease pathophysiology, which is also referred to as CNS compartmentalized inflammation and neurodegeneration. And this plays a role not only in the later stages of disease, where people often have dominant progressive features of disease, but can also play a substantial role even very early in the disease course. So I think it's becoming very clear, particularly because we have such easy access to high efficacy therapies that do, in many cases, an outstanding job of essentially suppressing most evidence of relapsing disease activity. We're recognizing more and more that in many people, even at the time of diagnosis or within a year or two of diagnosis, it's very clear that these CNS compartmentalized disease processes or progressive disease biology is at play. And so as you can see from this diagram here, traditionally, it was thought that relapse-associated worsening, or RAW, was really the only driver of disability progression in relapsing MS and in earlier stages of the disease, and that these relapse-independent progressive disease pathophysiologies didn't really contribute. But it turns out that is absolutely not the case. And as you can see from this diagram here, it is both relapse-associated worsening as well as progression that is independent of relapsing activity that is at play in the majority of people with MS across the entire disease spectrum. Of course, there are different proportions of RAW and PIRA that are at play in individual patients, and in general, in people earlier in the disease course, it is possible and often likely that RAW plays a more dominant component, while later in the disease course, PIRA plays a more dominant component. But again, the thinking in the field has clearly shifted to recognize that both RAW and PIRA have a role really across the entire MS disease spectrum. And so this is why there is so much interest in the field in newer therapies that potentially can target not just relapsing disease pathophysiologies, but also progressive disease pathophysiologies, which are these disease processes that are confined behind the closed blood-brain barrier, these CNS compartmentalized inflammatory processes. And so this is why there's so much interest in BTK inhibitors or Bruton's tyrosine kinase inhibitors, because these are molecules that we know play a key role in modulating B cell function, which, as we know, plays a major role in relapsing disease pathophysiology, but B cells confined behind the closed blood-brain barrier can also play a major role in progressive disease biology. And then, really importantly, we also know that BTK inhibitors play a very important role in modulating microglial activity, which we know is a dominant driver of progressive disease biology, compartmentalized to the central nervous system. And because Bruton's tyrosine kinase inhibitors are small molecules, many which can easily cross the blood brain barrier, there is quite a bit of interest in the MS field because they have the potential to modulate both peripheral and CNS compartmentalized disease processes responsible for relapsing and progressive disease biologies, respectively. And so this is why there's been such keen development of BTK inhibitors in the MS field. And although in the field we're used to molecules that belong to the same family of drug, it's not often that we have so many different molecules that belong to the same class of pharmacologic family being evaluated simultaneously in MS. And this is exactly what's happened with the Bruton's tyrosine kinase inhibitors. And it's to the point where at any one time in the last number of years, we've had usually anywhere between 4 to 6 different BTK inhibitors being evaluated. So I'm going to be going over a number of abstracts that were recently presented at the ECTRIMS 2025 meeting. We will talk about specifically BTK inhibitor abstracts in just a few moments, but just wanted to start with a few interesting studies that look specifically at healthcare burdens related to people with secondary progressive MS. So this was a retrospective matched cohort study that looked at clinical and financial burdens of people with SPMS matched to MS-free cohorts, and claims databases were used for approximately 5 years. And as you can see from this figure here, there were a number of frequent neurological complaints in people with SPMS. And in comparison to the match cohort, as you can see, the prevalence of these various neurological complaints was much more common in people with SPMS. And when all-cause total healthcare resource utilization and costs were evaluated, as you can see, people with SPMS had an over 8-fold greater total healthcare resource utilization and costs in comparison to the matched cohort, requiring more emergency department visits, a higher number of mean physician visits, and longer hospital stays, as well as more rehab services. So it's very clear that SPMS can be quite burdensome from a neurological standpoint to people living with the disease. But with respect to financial costs as well, it is quite burdensome from a societal level. And it's very clear that we need better treatments to try to address some of the neurological disability that is resulting in all of these additional visits for healthcare utilization. One of the challenges that we have in MS clinical practice is that we don't have great ways to monitor progression in MS. And we know that, particularly in this era where we're using a lot of high efficacy treatments that nearly get rid of any evidence of any clinical relapses or paraclinical evidence of relapsing disease activity, many people still have this PIRA that is actually often subtly progressive and quite difficult to measure. And so there are many attempts around the world at trying to figure out better clinical and paraclinical tools that will help us to identify subtle, some people call it smoldering progression when it's happening, and to monitor it over time. And one very interesting attempt at doing this is something called the Smoldering Associated Worsening Index. And there's a study happening right now where many people with MS are being interviewed to figure out what are the symptoms that matter most to people living with MS, and to try to devise a way that in the clinic, these symptoms can be effectively monitored using a combination of typical neurological tools as well as patient-reported outcome measures and targeted questioning from clinicians. And so this is a study that is taking place currently. Different domains are being evaluated to figure out what the most high yield domains are to evaluate in people with MS to try to get a clinical tool that can help us to monitor subtle disease progression over time. In addition, there are digital tools that hopefully may help us in this realm. And MS Detect is a study that is looking at a smartphone based digital tool, which includes a walking test, a cognitive test, a manual dexterity test, and a vision test. And this is being evaluated at many different sites around the world. So hopefully, eventually, we'll be able to land on some sort of digital tool that is relatively easy to use that clinicians can also use to monitor patients to see if there is a subtle progression over time. And these are early results from the study. And as you can see, there are quite good correlations between many of the tests that are being used on this digital app, as well as accepted tests that we currently use in MS clinical trials and practice for walking, dexterity, cognition, as well as visual acuity. So moving on specifically to some of the new BTK inhibitor data, as you well know, there's many different trials that have and are currently evaluating different BTK inhibitors in MS. And this is a table summarizing the many different BTK inhibitors that have been evaluated and are currently being evaluated. So, when you look at some of the recent analyses that have been reported from some of the key clinical trials, there are a number of interesting studies that have emerged at the recent ECTRIMS meeting from the pivotal Hercules phase 3 clinical trial. So, last year, the results of this trial were reported and offered new hope for the field. But just so as a refresher, as you recall, Hercules was a phase 3 clinical trial that looked at the effect of tolebrutinib versus placebo in people with non-relapsing SPMS. And these are the inclusion criteria here. And as you'll recall, the primary endpoint of this study was very clearly met, and tolebrutinib resulted in a 31% reduction in 6-month confirmed disability progression, as well as a 24% reduction in 3-month confirmed disability progression. And as you can see, with respect to one of the key secondary MRI endpoints, tolebrutinib resulted in a reduction in newer enlarging T2 lesions. And when you look at additional endpoints, including 6-month confirmed disability improvement, as you can see, there was a much higher proportion of people who were treated with tolebrutinib that experienced CDI. However, due to the statistical hierarchy, this p-value was considered nominal. Nonetheless, it is very interesting to look at that CDI endpoint as well. Curiously, tolebrutinib did not result, despite the fact that it very clearly met the primary and secondary endpoints, but it did not result in a difference in the rate of whole brain atrophy in comparison to placebo, as you can see from one of the figures here. So recently at ECTRIMS, subgroup analyses of the Hercules clinical trial were evaluated. And when you look at the primary endpoint of 6-month confirmed disability progression in people treated with tolebrutinib versus placebo, as you can see, based on different demographic as well as clinical characteristics, it's very clear that in general, tolebrutinib very clearly had an effect across most of the demographic and clinical subgroups. So I just wanted to highlight a few. So as you can see, in general, tolebrutinib across different epochs of baseline age seemed to have a clear effect on disability progression. In addition, when it came to people with more or less disability, although there is a difference in the magnitude of effect, it does seem that tolebrutinib seems to still consistently have an effect. And very importantly, many people often ask this question about whether there was an effect of tolebrutinib in people who had baseline GAD lesions versus those who did not. And as you'll recall, there were about a little over 12% of people who were treated in this trial with baseline GAD lesions. And as you can see, the magnitude of the effect is greater in people who had baseline GAD lesions, but there still very clearly is an effect in people who did not have baseline GAD lesions, which is reassuring. When another analysis was done looking at tolebrutinib plasma exposure and efficacy response, As you can see, when concentrations of tolebrutinib within the blood, as well as M2, which is the main metabolite of tolebrutinib, were evaluated, as you can see, the higher the exposure of tolebrutinib or its main metabolite, the greater the treatment effect. So it's very clear that having more tolebrutinib or the main metabolite in the bloodstream is associated with a higher rate of decrease in disability progression. And so I think it's important, should tolebrutinib become available, that it is taken as recommended specifically with food so that the greatest serum or plasma concentration can be maintained. We know that BTK inhibitors, by way of the mechanism of action, are immunomodulatory drugs. And when you look at immunoglobulin levels, both IgG and IgM in the Hercules clinical trial, it's reassuring because the mean leukocyte, lymphocyte, neutrophil, and monocyte counts remain stable and within normal range. And specifically with IgG levels, the mean IgG levels remained within normal range and were overall stable. And IgM levels similarly remained within normal range, although as you can see from the bottom figure here, the level of tolebrutinib treated participants, there was a slight decrease in IgM over time. And notably, thrombocytopenia, which is an AE of interest based on older BTK inhibitors that were studied in hematology as well as autoimmune conditions, occurred in only one participant in the tolebrutinib group, which is reassuring. PROs and the effect of DMTs on PROs are a subject of high interest because we know that some of the neurological disability scales that we currently use don't adequately capture quality of life. And so when you look at the MSQOL, which is a commonly used quality of life scale in the MS literature, this includes both physical health and mental health composites. As you can see on the left, with the physical health composite score at the 24-month mark, there was clearly a beneficial effect on this physical health composite of tolebrutinib versus placebo-treated participants. But at the end of the study, there were no between group differences apparent. And similarly with mental health at the 24-month mark, there was a benefit in people treated with tolebrutinib, but at the end of the study, there was no longer a difference apparent. And so probably many explanations for this, but it is somewhat reassuring that at least at the 24-month mark, there was clearly a benefit in physical and mental health composite scores. And as we know, many PROs can be quite variable. And so the lack of a difference that was clearly seen at the end of the study may be related to measurement variability. As a reminder, as you know, Gemini 1 and 2 results were reported last year as well. And these are the key phase 3 clinical trials that evaluated tolebrutinib versus teriflunomide, an active comparator, in people with relapsing MS. And as you can see, this is the study's design and the inclusion criteria of the study. And just to remind you, as you know, when the primary endpoint, which was annualized relapse rate, was evaluated in people treated with tolebrutinib versus teriflunomide, there was no difference in the ARR. And as you can see, both tolebrutinib and teriflunomide resulted in a reduction in the annualized relapse rate versus baseline, and they were quite low. However, what's really interesting is that when the key secondary endpoints of 3-month and 6-month confirmed disability worsening were evaluated, despite the fact that tolebrutinib and teriflunomide had a very similar effect on reducing relapses, as you can see very clearly, tolebrutinib was able to reduce the risk of disability progression um, much more so than the active comparator of teriflunomide. And so, as you can see here, it was a reduction of approximately 30% with respect to both 3-month CDW and 6-month CDW. So even though, according to the statistical hierarchy, because the primary endpoint was not met, these p-values for the 3-month and 6-month CDW are considered nominal. As you can see from the hazard ratio, there is clearly a difference in tolebrutinib's ability. Despite the fact that the reduction in relapses is very similar to the active comparator, there is an additional reduction of disability progression in people treated with tolebrutinib versus teriflunomide, even in relapsing MS. And so together with the Hercules clinical trial, this really does seem to illustrate the fact that tolebrutinib likely is a drug that is able to target compartmentalized disease processes that are responsible for progression that is independent of relapsing activity. So, when you specifically look at progression that is independent of relapse activity, or PIRA and RAW, in people treated with teriflunomide and tolebrutinib in Gemini 1 and 2, and this was a new analysis that was presented at the very recent ECTRIMS meeting. As you can see, when you look at the proportion of people treated with teriflunomide that had PIRA, which was 9.9%, versus those who were treated with tolebrutinib that had PIRA, which was 7.6%. It does seem that participants treated with tolebrutinib experienced fewer PIRA events versus teriflunomide. And again, although this is a post-hoc subgroup analysis, this seems to suggest that tolebrutinib is better able to target drivers of disability accumulation that are independent of relapsing activity. Similarly to Hercules, when blood immunoglobulin levels and immune cells were evaluated in Gemini 1 and 2, reassuringly, over 42 months, the mean leukocyte, lymphocyte, neutrophil, and monocyte counts remained stable in both groups in Gemini 1 and 2. And then when you look at IgG and IgM levels, as you can see, IgG levels remain stable in both groups and well above the lower limit of normal. And IgM levels also remained well above the lower limit of normal, but with tolebrutinib treated participants, there was a slightly higher decrease over time in comparison to teriflunomide treated participants. Moving on, long-term extension results of the phase 2 fenebrutinib trial were recently also presented at ECTRIMS. But by way of reminder, as you know, fenebrutinib is the third in-line BTK inhibitor that is currently being evaluated in MS. And last year, the phase 2 FENopta study results were reported. And this was a study that over 12 weeks evaluated fenebrutinib at 200 milligrams twice daily versus placebo in people with relapsing MS. And like most phase 2 clinical trials in relapsing MS, the primary endpoint was GAD-enhancing lesions, but combined at weeks 4, 8, and 12. So just as a reminder, the FENopta clinical trial was clearly positive and met its primary endpoint. When the primary endpoint of combined GAD lesions at weeks 4, 8, and 12 were evaluated, there was a nearly 70% reduction of fenebrutinib-treated participants versus placebo. But importantly, and also when you look at new or enlarging T2 lesions, there was a significant decrease as well. But importantly, when you look at GAD lesions at weeks 8 and 12, there was over a 90% reduction of GAD lesions in fenebrutinib treated participants versus placebo when you look at those individual time points. And I'm only saying this because, we tend to look at numbers and compare them across clinical trials, even though we're not supposed to, but the reduction in GAD lesions was quite high when you compare to other phase 2 trials of BTK inhibitors that have been reported. So, when you look at the 96-week extension data of FENopta, as you can see, the left-hand figure demonstrates GAD lesions, and the right-hand figure demonstrates newer enlarging T2 lesions. And as you can see, fenebrutinib-treated participants showed near suppression of a relapsing disease activity, at least based on GAD lesions and new T2 lesions. And this was sustained throughout the 96-week period with very, very low numbers of any GAD lesions or new T2 lesions. So really near suppression. And just wanted to highlight that this is somewhat unique compared to the other phase 2 trials of BTK inhibitors that have been presented, including tolebrutinib and evobrutinib, where, in the long-term extension studies of the phase 2 trials, there was some ongoing gadolinium enhancing or new T2 lesion activity, not the near suppression that you see here. So, of course, we don't have a head-to-head trial to compare, and the phase 3 trial results will be much more informative. But this is interesting because, at least with respect to relapsing disease activity based on GAD or new T2 lesions, there does seem to be somewhat of a difference with fenebrutinib in comparison to prior BTK inhibitor results that have been reported. Similarly, up until the 96-week mark, when you look at clinical endpoints, ARR remained very low at 0.06. And then when you look at the EDSS scores displayed on the right here, they remained really stable over time, as you can see here. When you look at B cells as well as IgM and IgG levels, as you can see, there was a reduction in B cell count that was continuing to reduce up until the 96-week mark in people treated with fenebrutinib. And then initially there was a decrease in IgM levels, which seemed to level out, as you can see from the middle figure here. And with IgG, there was a slight decrease compared to the baseline level, which is outlined in each of these figures with the gray dotted line here. All right, so now that we've summarized all of these recent data, just wanted to talk about a couple things related to what this means in clinical practice. So, as we've already outlined, again, there is so much interest in BTK inhibitors because we know that they have the potential to beneficially modulate B cells and microglia, which are highly relevant both in the periphery as well as centrally for relapsing and progressive disease biologies. And so, because BTK inhibitors are obviously can be taken orally and then are in the periphery. We're excited because we know B cells in the periphery play a major role in relapsing disease activity, but because they're small molecules that can quite easily cross the blood-brain barrier, and if they achieve relevant concentrations in the CNS, to be able to modulate, say, B cells and microglia confined within the CNS, which we know are drivers of progressive disease activity, these may be agents that are able to dual target both progressive and relapsing disease biologies, which is exactly what we need in MS. So when you look at CNS concentrations, when you look at tolebrutinib, as you can see here, even within a few hours of ingestion, very clearly tolebrutinib is able to achieve concentrations within the central nervous system that are relevant for microglial activation. And so, as you can see from the gray dotted line here, the concentrations of tolebrutinib are well above what is needed for the IC50 of microglia. And then similarly, fenebrutinib's CNS penetrance was evaluated in a small subset of people in the phase 2 Phenopta trial. And as you can see, again, within hours of ingestion, the CSF concentration of fenebrutinib is well above both the IC50s and the IC90s, relevant to both B cell as well as microglial activation. So this is reassuring because it tells you that people can achieve relevant concentrations of fenebrutinib within the CNS. And then similarly, really recently, remibrutinib, which was one of the newest BTK inhibitors that's being evaluated in MS, is also able to, within the CSF, achieve concentrations above the IC50 relevant for microglia, which is reassuring because crossing the blood-brain barrier is one thing, but obviously relevant concentrations need to be achieved if theoretically these drugs are going to be able to modulate the cells that we think are driving progressive disease activity. So, safety, obviously, in addition to efficacy, is always our primary concern as clinicians. And as you know, many of the BTK inhibitors that are currently being evaluated were placed on hold in the clinical development program. And in fact, 4 of them were placed on clinical holds because of liver-related safety concerns. What's evident is that from many of these clinical trials, it does seem that in a small proportion of people treated, usually within the first 3 months, there can be really high elevations of liver enzymes. And so it's very clear that, at least with many of these BTK inhibitors, this is a signal that we need to monitor carefully. And there will likely need to be very close monitoring should these drugs become available for use in clinical practice, at least within the first couple months of initiating therapy. I did want to note that there may be, though, although it's very clear that many of the BTK inhibitors have this liver-related safety signal, it is possible because of the different pharmacologic properties of these BTK inhibitors, where there clearly are differences in terms of binding, selectivity, potential to penetrate the central nervous system at meaningful concentrations, reversibility, that there very well may be differences in safety as well. And of the BTK inhibitors that are currently being evaluated, remibrutinib is the one in MS that has not yet had a clinical hold on it for a liver-related safety signal. But obviously, the results of the phase 3 trials will be very informative in determining the ultimate safety profile of each of these medications. So, as I already highlighted, there very clearly are these different pharmacologic properties of these BTK inhibitors. And it is very possible that these different pharmacologic properties may very well result in different clinical efficacies and safeties. And I think this is very clearly illustrated even by the first two BTK inhibitors that have been reported in phase 3 trials in MS, evobrutinib and tolebrutinib. Evobrutinib is not able to penetrate the CNS, at least at the doses used in the phase 3 clinical trials at relevant concentrations, whereas we know that tolebrutinib can. And this very well may have resulted in the very clear differences that we see on its effect on progression that is independent of relapsing activity. So, what does this mean for us in MS clinical practice? Well, obviously, I think the phase 3 trial results will be extremely informative, and ultimately, it will depend on the phase 3 trial results. But it's very clear that, at least based on what we know now, many of the BTK inhibitors do have an effect on relapsing disease activity, but that effect may be different. And so this may influence the place in therapy in terms of whether certain BTK inhibitors can be used in really active, aggressive relapsing MS, whereas others may only be able to modestly decrease that relapsing disease activity. In addition, it's very clear that many of these BTK inhibitors may have different effects on progressive disease biology. And so, depending on the clinical trial results, this will also determine its place in therapy. If a BTK inhibitor very clearly shows an effect on progression that is independent of relapsing activity, then it will be a suitable drug for people who are demonstrating progression independent of relapsing activity, and probably the first line therapy in these settings. There are also questions about whether combination therapy may be useful in the future. And I think it's an intriguing possibility. It's just that in the MS field, which is, MS is a disease that lasts for decades, if not a lifetime. Combination therapy always comes with it a risk of safety issues, as well as we can't forget cost. And so these are factors that will need to be taken into account. But theoretically, I think there is a really interesting role for combination therapy potentially in the future. Obviously, we'll have to learn more about the safety profile based on the phase 3 trials. And then the use of BTK inhibitors in women planning pregnancy and in the peripartum period, including breastfeeding, will obviously need to be evaluated over time. And then these issues with discontinuation and rebound will need to be evaluated, although there are some early results that have been reported before about tolebrutinib not having any rebound, at least based on the phase 2 clinical trial where there was a placebo run-in and run-out period. So it's an exciting time. And as you can see, there's many, many different clinical trials that are really simultaneously happening, although a little bit staggered, as you can see from this diagram here. We're at this mark here. As you can see, we're nearing the end of many of these clinical trials, including Perseus, FENhance 1 and 2, and FENtrepid. So really excited that we'll be hearing new results in the coming months to years. And hopefully these will ultimately result in new options for people living with MS so that we can maximize clinical outcomes. So that brings us to the end of our discussion for today. I hope you found this activity informative and useful to your clinical practice. I'd encourage you to explore additional program materials and engage further with other MS education resources at peerview.com. Thank you very much for your attention and for participating.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Sanofi. To access all materials for this activity, visit peerview.com/CXV860.